Bismillahirrahmanirrahim. Thanks for the organizers to inviting me to talk on this one of the most common, I think so, problem which we personally feel, and in day-to-day practice we do have. I don't think so there is a day when we miss a patient with constipation. The talk which is given to me is fiber and constipation. Before going to the management side of the constipation, I would first discuss what is constipation. And we came across patients who presents to us with multiple symptoms, and when we probe in, they say that I have constipation, but when we say, how many times you go to the washroom? He says, I go washroom 3 times a day, but still I am constipated. But what physician thinks that what is constipation? So I am sharing all these things in my talk. It's a polysymptomatic multifactorial disorder. One of the most common GI disorder, affects 15 to 20% of the population, and more prevalent in women, elderly women, and is substantial burden on healthcare resources. This is a study which was conducted way back in 2001, and it is basically the survey among the patients who presents to us with constipation. And just looking at this graph, if we say that 81% of the patients complain that they say constipation, that when they strain, they have constipation. 72 have hard or lumpy stool. 54 has incomplete emptying, like they keep on saying that I am not satisfied while I pass the stool. And stool can't be passed, so they have to do manual evacuation. So these are the things which we need to address. Then abdominal fullness and bloating, gas. Many people came to us that I have constipation. When we probe in, they say, मुझे पेट में अफरा की कैफियत रहती है, and they consider it constipation. And what physician thinks? Physician thinks that if a patient have less than 3 bowel movements per week, then this is a constipated patient. So considering all these symptomatology which patient presents to us, there is a consensus criteria for the diagnosis of constipation. This is a Rome 4 criteria. This is a Rome Foundation which have done excellent job in all the functional GI disorders. And they says that chronic constipation must include 2 or more of the followings. So it should be like patient can have straining and lumpy stool. He can have straining and sensation of incomplete evacuation. He can have straining with sensation, anorectal obstruction or blockage, manual maneuver to facilitate the defecation, and less than 3 defecations per week. And for chronic constipation, it should be more than 6 months. It should not be less than 6 months. So when we are talking about chronic constipation, mind it that history is very important. So we have to probe in what type of symptom he is giving us, and then we have fulfilled this criteria or not. This is a Bristol scoring stool chart. When I work in the one of the elite university, AJ University in Izmir, we used to have these charts in our pockets. When we used to do OPDs, we say to the patients what kind of stool they pass. So in type 1 and type 3, these are considered to be the constipated stools. So when they say that they have pellets, they have sausage-shaped stool but lumpy, they have sausage-shaped stool with the cracks. So these 3 types are considered to be constipated stools. Rome 4 has divided chronic constipation into functional constipation. It's a part of irritable bowel syndrome, opioid-induced constipation, and functional defecation disorders. So these all are constipations, but they have different dynamics. They have different pathophysiologies. When we classify constipation, we classify into primary and secondary. So primary is slow transit constipation, like our colon is slow and its movement is slow, that leads to increased absorption of the liquid content from the stool and make the stool more hard. Evacuation disorder, like patient have the urge but he cannot evacuate properly. Then we have IBS-C. And we have to rule out the secondary causes like drugs, especially opioids, the other drugs like antipsychotics, antidepressants, antihypertensive. These needs to be, there are certain antihypertensive like calcium channel blocker that can lead to constipation as well. Poor fiber intake and behavioral or some metabolic causes. I will skipping this. Okay, if we are, how our anorectal functions works. Whenever we have an urge, stool in the rectum, we have an urge. Mass movement, it leads to rectal distension, and whenever we have rectal distension, there is a reflux which causes our anal sphincters to the internal anal sphincter, which is not in the voluntary control, to stimulate that sphincter. Whenever this internal anal sphincter stimulated, it leads to voluntary external anal sphincter contraction. So whenever we have an urge and we want to go to the washroom, these sphincters stimulate the external anal sphincters, and we hold the sphincters and we rush to the washroom and then we release it because this is in our control. So this is one of the way or one of the normal physiology of anorectal function or defecation. Okay, whenever I talk to the patient, I always tell them that, look, passing a stool is just like a toothpaste. You get a tube, a new tube, it is full. You open the lid, you just press it, it's easily come out. But if we fill that tube to the half, like we empty half that tube, you keep on pressing it, some paste will come up, some will down, and there would be a less paste coming out of that orifice. So that is true with our rectum or our anorectal physiology as well. So for a proper evacuation, our rectum should be full enough, it should have a coordinated movement, and our sphincters should be open when we have our rectal contractions. So whenever our rectum is empty, we have an urge, we keep on straining, and there would be no satisfaction. Similarly, if the rectum is contracting and our anal sphincter is not opening, that again leads to anorectal dysenergy and we feel constipated. So for effective defecation, it has to be get full. You have to know it is full. You have got to squeeze it and take the lid off, and you have got to put the lid back or when finished. So this is the basic mechanism that how we defecate. Diagnostic workup. Do we really require diagnostic workup for all the patients with constipation? It all depends on the history. So on history, you have to rule out the red flags. Like if patient is complaining that he is constipated but he has bleeding as well. If he is saying that he has constipation but he has losing weight, or he has constipation but he also has anemia. So these are the red flags which you need to rule out on all the patients who are presented to you with constipation. Clinical examination, yes, it is important because you can look for the anemia, you can look for any abdominal masses on the clinical examination. So this is important for all the patients who have constipation. Digital rectal examination, very important. You can do it at your clinic, and that would give you a lot of information. Many of the patients in old age, when came to you with constipation, you prescribe them laxatives. You keep on giving them laxative and they come back to you with abdominal distension, not responding to your treatment or abdominal pain. When you put the finger in the rectum, there is hard impacted stool over there. So hard impacted stool is one of the cause in old patients who presented to you with constipation. Even, mind it, if an old patient came to you with diarrhea, you ask them, आपको स्टूल पास होता है जी? मुझे इनका स्टूल कंट्रोल ही नहीं होता. फैमिली कहती है जी स्टूल कंट्रोल ही नहीं होता. He keeps on passing stool, keeps on passing stool. And when you put the finger in, there is hard stool. It's basically spurious diarrhea. You give enema to that patient and patient is fine. So digital rectal examination is a very important tool in patients who are presented to you with constipation. And then comes the investigation. And investigation is not required in all the patients. They are required in patients who are not responding to your treatment, and secondly, who have red flags. We have a lot of investigation available in our part of the world: colonic transit studies, anorectal manometries, balloon expulsion test, defecography. I'm not going into detail of these things because these are the specialized thing, and we need to find out by doing these tests, we need to find that what type of constipation patient is having. Because in colonic transit study, we will look for the colonic transit time, that whether this is a slow transit constipation or it is a normal transit constipation. Because in a slow transit constipation, we need to stimulate the gut. So the choice of laxative are different. In patients who have a normal transit, in those the choice of laxatives are different. So if a patient have a normal transit and you give them stimulant laxatives, they will end up with diarrhea. If a patient have a slow transit constipation and you give them osmotic laxatives or you give them bulking laxatives, they will end up with bloating because they already have slow transit. And you keep on giving them fibers, you keep on giving them cinna, you keep on giving them the psyllium, they lead to bloating, like fullness of the abdomen. The second investigation, why it is important, anorectal manometry. This is important to find out that how patient evacuates. Because if the evacuation is faulty, like when they contract their rectum, at the same time they have contraction in the anal canal, like sphincter is same time contracting, you keep on giving them laxatives, they won't be getting better. Because problem is with evacuation, not with the colon. Defecography, this is a sinister investigation with the anorectal manometry to rule out rectocele and this and rest of the things. In those patients complaint in the history that they evacuate when they use manual maneuver. They use their fingers to evacuate. So this is one of the common thing which patients came to us with chronic constipation. So colonic transit study, this has been done with many techniques. One is the radiographs. We give the patient radiopaque substance in the meal and we keep on doing x-rays, and after 5 days we see how many radiolucent markers are there. So that would tell us that whether the patient have slow transit or normal transit. Similarly, we do have wireless capsule as well. That would tell us that how slow the transit is. Colonic transit studies, scintigraphy is another technique in which we give a specific meal to the patient and we keep on imaging the abdomen, and then we see that how much tracers are left in the colon so that we can have a proper diagnosis for inertia. Anorectal manometry, this is another tool which we use to do do in patients who have anorectal dyssynergia or patient is not responding to our therapy. MR defecography, again I have told you. So treatment algorithm for a normal transit constipation. As my talk is on fiber, so I'm more taking this normal transit constipation. So when patient presents to you, you always ask them for a dietary or proprietary fibers or milk of magnesia. Improvement is there, you continue with this diet regime. If no improvement, you add stimulant to that. If there is no improvement, you add PEG to that. So these are different type of laxatives which we have. Starting from the fiber, this is the bulk forming laxatives. Then we have Sina, our old friend, then the PEG solution, and then these are the rest of the newer drugs which we usually have in the patients. So management part is just 1 minute. In management, lifestyle modification, diet and fiber, laxatives, secretagogues, these are the choices which do have in patients who with the management of constipation. Ask the patient to take liquid, adequate amount of liquid, and it doesn't mean only water, it includes all the liquids like juices, milk, lassi, they can have everything. They should have a good exercise, at least 1 mile or 25 minutes per day. Position during defecation is very important because always tell the patients who are constipated that the normal position for passing the stool is squatting position, Indian toilet position. So when we use commodes, it tends to have generate an abnormal angle between rectum and anal canal, so we have a difficulty in defecation. So how can we solve that issue? Ask the patient to take a step under their feet while using the commodes. Like they place a footstep of almost one feet of height under their footsteps, they can have a normal angle and then they can evacuate easily. When to go to the washroom? Do the patients always, when you ask about the history in patient says that I go to the washroom every time, 3 times, I have an urge and rush to the washroom, tell them that don't do that like that, because in that cases your rectum is not full enough to evacuate easily. So in our population, what I came to know is generally second or third urge is good enough that patient have a good rectum and having a proper defecation. Supplementing the diet with fiber can be benefits. Why? Its water holding properties of the stool, form gels to provide stool lubrication and provide bulk for the stool and stimulate peristalsis. What is the dose of that fiber? Patient came to us that मैं तो इस सब गोल का छिलका भी खाता हूँ, मैं तो फाइबर बहुत लेता हूँ, फ्रूट बहुत लेता हूँ, लेकिन मुझे तो कॉन्स्टिपेशन ठीक नहीं होता. तो just there is a proper dose. So you start with low dose to 2 to 3 grams, 3 to 4 grams, and then keep on incrementing. And usual dose is 20 grams per day for the relief of constipation. Now come to the point that what type of fiber we use, whether soluble fiber or insoluble fiber. Studies showed that generally the soluble fibers are good as compared to insoluble fiber, because insoluble fibers generally ferments more and they produce more gases. So generally these patients have some sort of functional dyspepsia as well. So they are not comfortable with those. If the insoluble fiber is suiting them, it's good enough to continue that. If not, then the fiber, like the soluble fiber, is the choice of drug, choice of fiber or choice of diet they should include in their day-to-day practice. So the soluble fiber, we have psyllium, wheat dextran. You can add these in your daily meal and you can have a good response to that. Other laxatives like osmotic laxatives, PEG solution, lactulose, sorbitol. So these are what kind of constipation that is important with that. Stimulant laxatives are very old laxatives which we have. Sina and bisacodyl is in the form of tablets. So these are the drugs of choice in patients who have slow transit constipation. Now we have these newer drugs like procalopride, lubiprostone. they are basically secretory ducts. They secrete the water by chloride channels and they smoothen the stool and we can evacuate easily. Other treatments in patients, we have anorectal biofeedback mechanisms, transanal irrigation, nerve stimulation, and in rare cases, we will be going with the colonic surgeries. In chronic constipation, megacolons, in those cases, we remove the colon and anastomose the ileum with the rectum. In summary, all the patients who are presented to you with the constipation, they should have a detailed history, clinical examination. Investigation should be performed to look for type and cause of constipation. Reassurance and counseling of all the patients should be done. Lifestyle modification, adequate fiber, and what type of fiber, preferably soluble fiber, should be given to the patients and in proper dose. Not all the patients required laxatives, stimulant laxatives, but in a patients who have slow transit constipation, we need to go for these stimulant laxatives as well. Thank you so much for your patience. If you have any question, you can ask. At the end of the session,